Good morning.
Hey, Olivia.
Okay, so I just put that on.
Can you mute the room just like while we're getting gathered?
Oh, thank you.
Or like, you know what I mean, mute the mic in the room.
In your space, I sit right here. Is the room usually full or?
No.
Okay.
I mean, usually it does good.
Yeah.
It really fluctuates.
It seemed like there were more people online than.
Oh, there's always way more people online. Yeah.
Okay.
But, like occasionally I am like. Does the timing work for you? We have you at the end.
Oh, I didn't know that. I thought we were in the beginning.
Oh no, I'm sorry. Department updates are at the end. But like not the very end.
Yeah,
So
the
when I
MEA
arrived-
part is, the MEA part is in the end too?
Yes.
Oh, I thought it was in the beginning.
Me too. Well, the rule is in the beginning. So, oh, sorry.
Deep breaths.
Yes,
wonder
your
we
rule
need
is
to-
in the beginning. I'm sorry.
I thought the
You're right.
MEA was in the beginning.
Let's look at the agenda.
But it is a rule, right?
It is, well, there is a rule, but we're not doing rulemaking on
No, they're not even in the room yet. What are you talking about?
it. 801,
Not 801, 805.
well, 805, yeah.
And 310.
Yes, I know those, but if we're talking about the MEA, which I think is what we're talking about, and I derived from one of the communications that we were on early.
Yeah.
Yeah.
Can you hear us?
Sounds good.
Hey, if you need a
Lisa,
lifeline.
Britt, and Kelly, you're both here. I wanted to just ask if we could consider, we have a time for agenda items for future meetings and the presentation on NDAs. That's we move up in the agenda right now.
Like cell based?
Do you like a rearrange? Would that be okay?
Okay, if she does a little rearranging.
Is the mic-
Sure.
Yeah, so then we would go to that at 7:30. You know. Yeah, we actually went on. Okay, Kristen, let me know when we have a quorum.
Trying to ignore my UV key message to you.
I see a quorum.
Yeah.
I think we're ready to get started.
Did you say we've got a quorum?
Yes, sorry.
Yeah, sorry.
Okay. Good morning, everybody. Thank you for joining us. Thank you for your flexibility in letting me participate from home this morning. Normally, I like to be with you in person. I'm not sure because I can't really see the room if there's anybody that we need to introduce.
Yes. Yeah, we'll do some intros. Can you hear us okay?
Mhm.
Okay,
Yep.
great. So let's go around the room quickly. Kristen, can you go first?
Kristen Finnebrock, Administrative Assistant.
Henry Lippman, Medicaid Director.
David Shorty, Deputy Medicaid Director.
Olivia May, Director of Medicaid Enterprise Development.
And the Jean Greco, and the Market Chief Medical Officer at AmeriHealth, and I'm excited to join you. Kelly Cappuccino.
Christina Ickes, the Administrator for Long-Term Care for Bureau of Aging and Adult Services.
Hi, Wendy Altman, Bureau Chief of the Bureau of Adult and Aging Services.
David Badarai, Communications Director at the Disability Rights Center in New Hampshire.
Okay. Good morning, everybody. Olivia or Henry, do we have announcements to follow up our introductions, or should we dive right in?
I don't have any.
I think we're good for you to go. Thank you.
All right, great. So on the consent agenda, we have a lot of rules. We probably got a handful of emails over the course of the last week. I guess my question to the group is, are there any rules on this list that you would like to see come off the consent agenda? If we take it off the consent agenda, we won't discuss it right this second, but it is a notation that we do need to have a more fulsome conversation. So are there any members that would like to take any of these rules off the consent agenda? Kristen, are you seeing any hands or anything out there?
Nothing in the chat.
Nothing
No
in the,
hands. Yeah.
Going once, going twice. Okay, these rules will stay on the consent agenda. Thank you. So we need to approve minutes, the July and August. I think they came out, what, late Friday?
Lisa,
maybe-
it's Carolyn. I had my hand raised.
Sorry,
Is there-
Carolyn, proceed.
Sorry,
I was just going to recommend that you read the list, please,
Okay.
for the
Sure.
record, where the agenda is not part of the record. Thank you.
Sure, Carolyn. Okay, the rules on the consent agenda include HEW 53004, co-payments, HEW 57013, prescription co-payments, HEW 572, ambulance services, specifically 57204, covered services, 57207, documentation, and 57210, payment services. HEW 568, this is physical therapy, occupational therapy, recreational therapy, and services for individuals with speech, hearing, and language disorders. HEW 80301, authorized representative. HEW 80302, individual responsibility to supply accurate information. And 80303, individual responsibility to report changes. HEW 80668, adult OAA, APTD, and A and B employment expense disregard, and 80669, impairment-related work expenses. HEW 85416, adult standard disregard, 85417, post-eligibility computation of cost of care for nursing facility care, 85418, adult employment expense disregard, and 85421, allocated income. And the last rule on the consent agenda is HEE 310, rights of individuals receiving choices for independence in the community. That concludes the consent agenda. Shall we move on to minutes from July and August?
Yes.
Excellent. So as I had started to say, I believe everybody got those minutes in the last, I don't know, 3-4 days. Let's pick up July 1st. Does anybody have either edits to offer or a motion?
Marissa?
So for the July minutes on page 4, there's a notation that defines the ABD waiver as age, blind, and disabled. That's incorrect. The ABD waiver is the acquired brain disorder waiver.
Thank you for catching that. We'll make that correction.
Any other suggestions or edits for the July minutes? Kristen, if we're clear, oh, go ahead.
I don't necessarily have an edit, but at some point I'm interested in knowing, there's a lot of sort of things to carry to future meetings, and I want to understand how we ensure as a group that those questions aren't lost. So not necessarily for the meetings, but just looking at the minutes, there were a lot of things for the department to come back with. And I just want to make sure that we don't lose track of those items.
I think we're
So,
carrying those in the future
Marissa,
department.
when we put together agendas for future meetings, and just for your benefit, that's Olivia, David, Henry, Kelly, and myself, with Kristen's support. We sort of start with the loose ends from the prior meeting and use those to inform future agendas. But sometimes the department needs more time to be able to put together a fulsome presentation on on some of those items. So you might not necessarily see it on the very next agenda, and it would be carried as for future meetings. So I'm just concerned, are you saying that there are things that you understood we would be talking about that haven't been picked up and don't appear on the, items for future meetings, or this is like a generalized concern?
No, just a generalized concern, just making sure that at some point, it's not necessarily a rush, but at some point they're addressed. There's a lot of questions I think that a lot of members come up with over time. And just is there like a running list but that's helpful to know. Thank you.
So Lisa, it probably stems from us having a new cadence with
Well-
meetings. We've talked about that. We added a little section at the end of this agenda that is future department updates. And we can talk about capturing outstanding items, either in that category or another category. But we can take that back to our meeting with the team here at DHHS.
Yeah, and Marissa, your comment also just makes me think of like, there are things that get raised that we handle offline. So like, in one of the prior meetings, someone raised feedback about well senses, NEMT communication. And so then, after the meeting, we follow up with well sense and our NEMT team, but it doesn't necessarily become an agenda item because it's more like an item was raised that helped us do some follow-up. So we can try to be more thoughtful about like maybe just sharing a brief verbal update when that happens. Is that kind of what you're thinking when you see in the minutes, like we're gonna like look into something based on a comment raised?
Yeah, just making sure that things don't get lost, just due to the volume of work and discussion and topics that this group talks about. Just making sure
Yeah.
that things don't get lost over time, especially, and I agree, Kelly, the cadence is throwing me a bit. So, which, obviously that had to be done, but I just want to make sure things don't go missing over time. Thank you.
And definitely if folks do just have questions about, hey, when are we gonna hear about this, please just raise it in the meetings. That helps us too.
So refocusing back on the July minutes, it sounds like we have one non-substantive edit. Are there any other suggestions or edits for the July minutes?
I make a motion to approve the July minutes with that edit.
Do we have a second?
I'll second.
Okay. Any discussion? All in favor? Aye.
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 Okay, let's move on to the August minutes then. Does anybody have suggestions or edits for the August minutes? Are you seeing anything in the chat, Kristen?
Nothing. And we don't see any hands up.
Excellent. So can we have a motion to approve the August minutes, please?
So
So
moved.
moved. I'll second.
Who was the first?
Who
Holly
made the
Stevens.
motion?
Oh, Holly.
Thank you, Holly.
Thank you.
Thank you. Any discussion? All in favor?
Aye.
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 Excellent. Did you get all of the votes, Kristen?
Yep.
Excellent. Okay, great. So let's move on to membership. And I think we sort of touched on this in the introductions, but recall that we will now have rotating representatives from the managed care organizations on the committee. Luann, help me with your last name, please.
It's Gian Greco.
Giangreco. So Luann Giangreco, who I understand is the Chief Medical Officer at AmeriHealth, is joining the committee now. Kelly, from the membership subcommittee, anything else you'd like to add?
That's it. Welcome, Luann. Happy to have you here.
Thank you, Luann. I look forward to meeting you in person. Okay, so in terms of a future agenda item, we're still carrying the workforce issues for direct support workers. Are there other items that members would like to see covered at future MAC meetings?
Polly?
Yeah, just if we can continue to monitor any impacts in the Medicaid program from the changes that we're going to be seeing in the next few months, including the co-payments and the premiums.
I think that's actually going to be our next, well, 2 items from now when we talk about federal and state legislative updates.
Perfect, thank you.
Yeah, I think that's going to be kind of a standing item for a while. Anything else? Okay, well, just because you don't say so now doesn't mean you can't say so later. You can always add suggestions by reaching out to Kelly or myself or David, Olivia, and Henry. We're happy to consider suggestions at any time.
Lisa Britt.
Yes.
So since we're running a little ahead of schedule, and I asked at the beginning of the meeting if we could move up our MEA presentation. I had a miscommunication, or I caused a miscommunication about staff availability. So if that's all right with the group to go to that next instead of under department updates, that would be great.
There was something in the chat.
Oh.
Sorry. Lisa Adams asked, would like to discuss Medicaid cuts to home health services by MCOs.
For a future agenda item.
Is that for a future?
Looks like Ben also has an item in the chat.
Yeah, and then Ben Bradley asked, work requirement look back 3 months versus 1 month. And Lisa said, yeah, for future agenda item.
Thank
Got
you.
both of those.
Yeah, thank you.
Lisa Brett, hi, this
Yes.
is Ellen. I can't
Hi, Ellen.
I can't figure out how to appropriately raise my hand with which button to push, so sorry to just blurt out, but this is Ellen Keith, and I'm not sure this needs to be on the agenda, but at some point it bears some discussion, as there are some definite and clear patterns of disincentives for reimbursement from some of the new transportation companies with some of the HMOs. So I know a lot of folks are having real frustrations with that. So at some point it would be good to be able to discuss that, but I'm not sure it belongs on the agenda.
Well, we will take that under advisement and figure out the best way to get some sunlight on that, Ellen.
Okay, that would be great. Thank you.
Sure. Okay, and again, we like to make the request for agenda items if there's something really burning on your mind, but you can always make those suggestions even if it's not in this little section of the agenda. So Olivia, I think you wanted to jump to the MEA. Is that right?
Yes, I'd like to hand it to Wendy Altman for presentation.
Hi, everybody. I'm just gonna share my screen. I have sorry, I'm dealing with one screen instead of multiple, so. Right. Ooh, technology.
I'm impressed.
It looks different on my screen than it does on that screen, so it like automatically knows what to do. I like that. So, as I introduced myself, I'm Wendy Altman. I'm the Bureau Chief for the Bureau of Adult and Aging Services, and our Bureau administers one of the 4 home and community-based service waivers that we have here in New Hampshire. And for, I think, many months, there had been a request for information and an overview around how we do medical or functional eligibility for our Choices for Independence waiver as it relates to the level of care. And we put together a slide deck of just talking about what to expect as things currently are operationalized today, and then have some information about some improvements and work that we've done that we anticipate and envision implementing. So I've asked Christina to cover the first part of it in terms of what it looks like today, and then I'll start to cover some of those improvements and work that we've done to date. So Christina?
Sure. And can everybody hear me all right? I'm not logged in through the Teams. I just wanted to make sure I'm being picked up all right. And people on the
think they're
Teams meeting?
nodding.
Lisa Brick, can you hear?
Yes.
Yes.
Yeah, okay, fantastic. So today we're going to be discussing how the current MEA process works. It's described at a very high level throughout the HEE 801 rule and then operationalized through the long-term care medical eligibility unit. If we can forward the slide. Currently, when someone is applying for Choices for Independence, their application is going on 2 tracks. There's a financial track and a medical track, and the 2 tracks run simultaneously. In some cases, the financial may be determined to be eligible first, or the medical may be determined to be in place first, but it takes both combined for somebody to be open for the program. People can apply online. They can go to their ARC, they can go to district offices. But after an application has been introduced into the department will set up an intake meeting at the Bureau of Family Assistance site. If someone has checked off that they want home and community-based services for CFI, or if they indicate during their intake meeting that they would like to pursue one of the home and community-based waivers for Choices for Independence, then the application is triggered for the MEA. The MEA is an assessment that's done for people, performed by a nurse or specialized medical professional who's going to meet with the program applicant to review their current medical status, to collect information that can be used by a reviewer to ensure that the person meets the criteria for nursing facility level of care. The MEA appointment is not scheduled by the applicant. It will be scheduled either by a Centra or department staff supporting Centra if needed. Next slide. I think it's important to just differentiate that, or to amplify that nursing facility level of care is the same standard across nursing facilities and Choices for Independence. And when we consider that a person that's in a nursing facility has a facility that's open 24 hours a day, that facility is not constantly providing hands-on care throughout those 24/7 periods. The person might have hands-on care for certain periods of time, support for their meals, support for ambulation, bathing, but otherwise might be enjoying time in their room reading, or in the facility enjoying an activity, or doing something else. It's not constant hands-on care. Where in a home and community-based setting, that's also true. A person may be eligible for nursing facility level of care and receiving their care at home, but they may only need a certain number of hours of hands-on care, personal care, meal preparation, that sort of thing, and otherwise can enjoy their life in their living room reading, or out enjoying activities or people in their home. So the nursing facility level of care is a criteria where a person is found eligible under standards that are articulated in the RSA 151(e)(3. And that is if they need regular help from nurses for medical treatments or monitoring, daily therapy or rehabilitation, help with at least 2 tasks associated with activities of daily living, such as eating, bathing, dressing, or moving safely. I also think it's really important to note that people don't need to meet the highest criteria for level of care. They don't need to meet the ceiling, if you will. There's a floor. They can have the minimum medical and functional standards. So for example, if someone needs assistance with medication administration, they can be found eligible for CFI solely on the med administration. Otherwise, they may need to meet under the activities of daily living or other criteria. So again, I'll just amplify that nursing facility care is available 24/7, but residents don't receive that care on a continuous one-to-one basis. In 2023, for example, nursing facility residents received on average 3.77 hours of direct care per day. And CMS has an expectation that by May of 2027, people will be receiving 3.48 hours of total staffing. So about just over a half hour, 0.55 hours of nursing, and 0.45 hours, for nursing aides. And that's under 42 CFR 483.35. When the MEA is completed, there's a review, and the review is done to determine what are the medical needs, how often help is needed, safety, supervision, and complexity of care, functional needs such as medication management, rehabilitative or restorative therapies, assistance with the greater of 2 or more activities of daily living, or eating, toileting, transferring, bathing, dressing, or continence. I think that the real key point here is that meeting nursing facility level of care means that the person needs at least the minimum medical and functional support required under RSA 151(e)(3), whether the care is provided in a facility or at home under the home community-based CFI waiver. The MEA is a face-to-face clinical assessment that's used to help determine if someone meets functional criteria for CFI, conducted by skilled medical professionals who've gone through training using a department-approved tool. I think it's important to just note that we describe that a nurse or similarly trained professional needs review use needs and documents to help. And we have a guidance memo that the department published that's available through a URL that's noted on the screen. Today, the assessment is performed by skilled medical personnel that the department has a contract with an outside agency named Accentra, and the department staff help support the MEA process. The performance of the clinical assessment reviews for nursing facilities and the CFI program meet the criteria of skilled medical professional or skilled professional medical professional, SPMP. The Accentra staff that conduct the assessment are known as the assessors, and they're required to meet the criteria of skilled professional medical personnel. On occasion, the department does have other skilled medical personnel that are certified, they're trained, they've tested to perform the MEA. So for example, a hospital discharge planner or a hospital RN may also go through the training to perform the MEA if a person is inpatient at a facility. The New Hampshire Department of Health and Human Services certifies an individual seeking to be designated as an assessor that they meet the education or certification requirements to be a skilled professional medical personnel and pass the testing requirement. The RSA 151(e)(3) delineates that the skilled professional medical personnel employed by or designated by the department shall determine the clinical eligibility. The federal statute 42 CFR 432.50 outlines the criteria and qualifications for a skilled medical professional, and department personnel with the function of skilled professional medical personnel have their credentials certified and reviewed by the Department of Health and Human Services Human Resources prior to being sent to the hiring manager for consideration. Their credentials are also reviewed directly by the hiring manager and legal counsel to determine whether an applicant to one of our positions possesses the proper credentials or education necessary to ensure the integrity of the hiring process. Can we fold this slide? So the MEA scoring has a numerical measure of a person's potential eligibility for nursing facility level of care. Higher scores suggest a greater need, lower scores suggest fewer needs, but the score alone does not determine the medical eligibility. The assessors may also be reviewing the notes, comments, or medical records when the score doesn't fully reflect a person's condition. So, for example, a low score may result from underreporting or misunderstanding the needs of a person when the assessment is done. A higher score could reflect that a person has had an injury, that they are still in an acute or subacute phase of their recovery, and that it may change as recovery occurs. An ongoing assessment suggests that they have improvement. The minimum data set is another instrument that is used to determine eligibility for CFI. The minimum data set is among the requirements of the Omnibus Reconciliation Act of 1987, a federally mandated process for Medicare and Medicaid certified facilities. So prior to admission in a nursing facility, an individual needs or is assessed to ensure that they meet nursing facility level of care. An MDS is regularly performed at a facility in 90-day intervals while in a nursing facility. So, for example, if at a time of a discharge, a person who meets nursing facility level of care on an MDS may continue to meet nursing facility level of care, but no longer wish to receive that nursing facility level of care service, and they want to have it in the community via CFI, or they may no longer meet nursing facility level of care. If the MDS is used to determine an applicant eligible for CFI and that they meet nursing facility level of care, their MDS eligibility would continue at the discharge. If they no longer meet the nursing facility level of care, then a new MEA is performed, and they may no longer meet the medical requirements for nursing facility level of care required for CFI eligibility. An additional instrument is also allowed under the CFI waiver, and that's the Outcome and Assessment Information Set, OASIS. The OASIS is a group of standard data elements that home health agencies integrate into their comprehensive assessment to collect and report quality data to CMS. The OASIS was introduced to the CFI waiver as an additional eligibility assessment for CFI in 2017. Regardless of an MEA or an OASIS score, the ultimate decision is based on the judgment of skilled professional medical personnel. Their clinical judgment may confirm eligibility or result in a denial of eligibility based on all of the information presented. If additional medical records are requested and supplied, the skilled medical professional will carefully evaluate the records alongside the OASIS or the MEA. The supplemental information that may be provided in medical records is incorporated to form a holistic view of an individual's healthcare and personal needs. When cases are being considered for denial, two skilled medical professional personnel will review the information and recommend the denial. Cases will then be reviewed prior to finalizing denials to ensure that all timelines were met, all appropriate steps were taken. So in other words, it takes two people to find a person ineligible. But at least, it takes at least two people to find a person ineligible, and the supervisor will review the cases to the denial before the denials are finalized to ensure that the DHHS procedures were followed.
Can I ask a question?
Sure, go ahead.
So can I infer all that to mean that if somebody is determined ineligible or appears that they may be determined ineligible, you take the cautious step of requesting additional information like you do in the initial application?
Yes.
Because my family member went to their interview and I was present and said they had no needs. And they had no needs because all their needs were being met through the waiver. And I had to prompt and say, well, so who administers your medication? Who's doing your laundry? Who's helping you in the morning get out of bed and do, your shaving and things like that? And all of that then made it, it was just the interview.
Right.
But, okay, so thank you. Sorry for the interruption.
No,
everybody.
great question. And I'm going to turn over the presentation now to Wendy, who's going to be talking about some of the improvements that are being made in the process. Thanks, Wendy.
All right, so as part of the DHHS roadmap, there are a couple of goals within the roadmap that speak to making eligibility easier. The majority of that is in and around financial eligibility, initial eligibility, but there are some components related to clinical and functional eligibility. One of those is related to aligning with the mission in terms of making sure that we're streamlining And also looking into our redetermination process to make sure once people do become eligible, and they are eligible, that process of redetermination can be made easier. So that's, we want to keep them and have continuous eligibility.
On both the financial and the.
Yes, on both financial, where we have work groups, both internal and cross-functional between the Division of Medicaid, the Division of Economic Stability, and our Division of Long-Term Services and Supports, who are working on both the financial eligibility component for long-term services and supports and clinical eligibility. So I'll be speaking to the clinical eligibility piece and what we've been working on. So one of the work products that we've been gathering with a work group of stakeholders that included both nursing facilities, providers of CFI services, hospitals, and teams here internal to the department. We met over several months to look at both the clinical or functional eligibility components as well as PASSAR screening, which is required for individuals who would be entering into a Medicaid certified facility. So I'll be speaking to the medical eligibility assessment components to this. So we convened the stakeholder group. We looked at what goal or vision we had for shortening the medical eligibility assessment component to really focus on the eligibility pieces required in our statute, and shifting or transitioning the items that were part of the medical eligibility assessment that were more about person-centered plan requirements to the person-centered planning process that happens after eligibility is determined. We also reviewed the PASSAR process, and we do have some, goals and components that we want to work on related to PASSAR as well, but we can talk about that at a later date or provide additional details. We also had department staff shadow financial and medical eligibility staff to look at their operations and their processes, look at any redundancy or administrative burden that staff may be feeling, to look at components that could be streamlined as it relates to their day-to-day operations. We held interactive meetings with staff. We looked through the lens of the people who are doing this work to come up with some of the thoughts and ideas related to how we would streamline things. So in terms of improving that public-facing process, we're in the process of developing and finalizing the request for proposal for a new contract for medical eligibility assessing and PASSAR assessing. We hope that will be posted. It'll probably be posted, I hope. I can't make a promise, but I hope between Thanksgiving and Christmas. My hope is hopefully before the end of November, that will be posted, in the hopes that we will have new contractors or new vendors doing this work starting July 1st. We are also updating the MEA form for the process for medical determination. And we've created some, items here to just give you an overview of what work has been done up to this point. We've set up this work group to assist the department in refining the medical eligibility and PASSAR. We've between April and October, we had meetings and work in between meetings to make these improvements and recommendations. And one of the results of that is we've identified being able to reduce the medical eligibility assessment from 14 pages to 3 pages, focusing on primarily on the eligibility components for nursing facility level of care, and streamlining the annual medical redetermination process and thoughts related to that. And the goal is to make CFI eligibility faster, simpler, more person-centered, and to keep the care that individuals are eligible for without those gaps or extra paperwork once they have been determined eligible. We want to eliminate what we call the churn of folks coming off the program and back onto the program. We are looking at not just improving the form, but the process, which will require amendments to our home and community-based waiver to ensure that we have the authority to make those changes within the redetermination process. But our plans are to create what we call an ex parte or automatically renewal for certain folks within the CFI eligibility program. We've communicated to CMS that is our intent and what our process would look like at a high level, so that we sort of gave them a pre-soak of what we intend to do when we do amend the waiver this year, and to get their initial feedback. But we intend to have an ex parte for clinical eligibility based on information we have within our New Heights system already. And then for folks who could be questionable or score really low, we'll have an attestation process in place where case management agencies would be able to attest that nursing facility level of care persists based on their needs and what they're getting within their person-centered plan, which is, precedented with other states and how they perform redetermination. And we would also look at a way to ensure that whoever our new vendor is conducting clinical assessments for initial eligibility had the ability to assess individuals that may need that during the redetermination process. So we can assign to cover that, and we can assign to look at representative sample and have a quality component to the annual functional eligibility requirement that we have at the federal level.
Wendy?
Yes.
Just a note, and can you go back to the last slide quickly? So that for future follow-up. It would be helpful, I know for me, and I assume then for other people, only cases showing improvement or major changes, just to have a better understanding of what improvement means in terms of me getting a sense of what we need to do a full assessment of, but we don't have to go there.
Yeah, I think that one of the things that we are looking at is, we did get feedback from many of our stakeholders, including advocates, as it relates to the medical eligibility assessment and the scoring component of that. And also, as we look at utilization of services, when you look at utilization of services and what kind of CFI services they're getting, whether it's direct care and help with activities of daily living within those services, or if it's not hands-on care services that they're utilizing, all of those components would come into play during redetermination.
As far as stakeholders go, you've mentioned a number of them, including advocates. Did you have any folks on the consumer side who are actually members or using the CFI waiver, host facilities, and feedback in the process?
Yeah, so we have not had a general public comment component to this yet. We have heard from both New Hampshire Legal Assistance, Disability Rights, and others related to the medical eligibility scoring and considerations that they want the department to have as they go through this process. So we will be taking all of that into consideration. And we certainly will have, as we embark on changing this process, have plenty of opportunity for public comment and feedback as it relates to that. We do have our National Core Indicators Experience Survey coming back, that data from all of the surveys that were conducted on Choices for Independence waiver individuals last year. That data and analysis is currently happening now. So probably in a future MAC meeting, we would be able to provide information related to what we heard from individuals who are getting services through the Choices for Independence.
Going forward, I think will be helpful because we have the BAC, Beneficiary Advisory Committee.
Yeah.
And you'll have, I know it's hard sometimes to get the voices that we need to inform this, but I think we have another new pathway that will be helpful to that. We have a question from Carolyn, I'm sorry.
Okay.
Carolyn?
Yes, it's a more of a, it is a question for Wendy. Wendy, during the meetings that you talked about, which were very helpful in this process, so thank you for that. One of the concerns raised was in regard to care provided by unpaid individuals. So as an example, there was a nun who was in a convent, and her sisters, not literal sisters, were providing most of the hands-on care, and she did not meet the criteria of the MEA as needing assistance in accordance with the guidance, but she was receiving assistance. It just wasn't paid. So the recommendation was that there should be a place on the new MEA for unpaid care to be assessed. And I haven't heard anyone speak to that, and I just want to make sure it happened.
And before you respond to her, I would strongly second that. It's literally, Carolyn, the conversation I was having in my head. Because for my loved one, I did all of that. You know, he was still in such trauma about the onset that he needed me. I did all that care. And as I would plan to have backed out and leaned in more to the support, so you wouldn't have seen it paid.
I'm not sure if the need that's being assessed asks whether it's paid or unpaid. It just looks at what the need is. So sometimes it's related to how the interview questions are asked, and that can be, weaved into the guidance and work instructions that we provide for assessors. So certainly a lot of the feedback that we got from the group are things that we said, we still need to make that consider that when looking at training and the work that we have that we expect from assessors.
Follow up, Wendy, follow up, where you're moving into a model where you may approve without another MEA based on services being provided. This care would not be reflected in paid services. So you need a mechanism to capture unpaid care that's being delivered, so these people aren't screened out.
Right, I see what you're saying, so that there's something captured within the system to show paid and unpaid, so not just looking at offers.
Even the case manager in their attestation, I mean, they came to see my brother every month, so they could attest to all the needs they were identifying, and I was meeting them.
Right, so as long as we're capturing that as part of the process and the mechanism for what data we have to use to attest for continued eligibility, that's what we're looking for to streamline that so that we're reducing the amount of face-to-face assessments and appointments that have to happen in the community, and the additional medical documentation and paperwork that we're asking for in the redetermination process. So really trying to reduce that piece. So this slide really demonstrates at a high level what we're focused on achieving over these next several months and into the year. I'm really looking forward to getting the feedback from CMS on our initial thoughts on how we want to move forward in doing this. I think the why it matters is really the driver for us really having these goals. Maintaining that quality and compliance is really important, but ensuring a more an easier process for individuals and providers who have to work as part of this process is also very important. And we also wanted to ensure that it aligns with CMS's guidance that they've provided to states related to streamlining eligibility and the guidance that they've given to us related to home and community-based services and best practices. So it does really align with all of that, and really the key takeaway is less burden, fewer delays, ensuring the same quality and that commitment to the person-centered care and service continuity, not having that gap. And also in alignment with this are some of the long-term services and supports IT enhancements that we've been focused on and continue to work through. And so I've just provided a snapshot of the areas where we've achieved those IT enhancements, but also where things are in progress. So focusing on the in progress, we are we've put together a group of folks to sort of introduce the New Hampshire Easy enhancement tool that allows for referring between the case manager and providers. Currently, right now, that all happens outside of the IT system. So we're going to start a pilot work group to do that. And so those IT enhancements are currently happening. We're looking at new letters and notices for clear understanding of eligibility. We're going to work on updating the MEA in that shortened version, which will take IT changes to make happen. We've also have our aging and disability resource centers have their New Hampshire Easy portal. So when they're helping individuals with applications, they have dashboards and can track those applications. Also, we're automating the Adult Protective Services registry checks, which currently happens outside of our system. And we are working on public-facing dashboards that will be included in those other dashboards that happen right now on the public health website. There'll be an interface for Choices for Independence, and we anticipate those before the end of the new year to be public. And I don't know if there's any other questions in the chat, but I think my time is up.
Are there any other questions in the chat for Wendy?
Cheryl Steinberg just said she's happy to share the MEA best practices document. NHLA shared with Wendy. She said she couldn't attach it to the chat, so I said to send it to me by email.
Great, thank you. Christina and Wendy, thank you very much.
Thank you.
Thank you all.
Thank you, Wendy. Thank you, Christina. All right, so Olivia, shall we bump back up to the MAC BAC transition agenda item?
Thanks, Lisa Brett. So there are three main items I wanted to cover. We've had this agenda item of MAC and BAC transition for the last few months as we've made our restructuring on this forum and inclusion of the BAC in line with CMS rules. We have three kind of agenda items. One is to do votes for the chair and vice chair of MAC. I then wanted to make a quick plug around rulemaking now that we're on this new quarterly agenda, and some food for thought on how we address proposed rules. I want to seed some feedback from the group on for a future meeting. And then I'll also just share updates on the BAC. We had our first meeting with the Beneficiary Advisory Council, so I was going to recap that as well. So let's start with chair and vice chair. We've had nominations open for a bit, and we have really only received nominations for Lisa Britt and Kelly, our existing chair and vice chair, which, it's excellent to have our nominations in. Because there were not other nominations, there didn't end up being like a subcommittee to vet nominations. And so that's really what we have to present for the group today is votes on proposed nomination for Lisa Brett as chair and Kelly Cappuccino as vice chair. Just a quick note, because we did run a little bit behind in some of this governance and transitioning the forums. This would still be a July to July term. We're going to try to catch up on this process as we get to next summer and future years of the MAC and BAC. So I'm going to open for any questions or comments.
Nominations from the floor.
Or nominations, thanks, sorry. Any nominations from the floor, thank you. Okay, if there's no other nominations, and just to say, I don't see anyone's hand raised, so if you are trying to do that, just go ahead and come off mute. And I don't see anything in the chat. So Lisa Brett, not to put you in a strange position, but do you mind calling the vote for chair and vice chair?
Sure.
Do you want someone else to do it, just to not put Lisa Britt in that?
Oh, sure.
I mean,
Brooke,
what's
thank you
helpful?
for volunteering. I appreciate that.
Oh, did I just volunteer? I would like to make a vote to make, to move, for the vote for chair and vice chair.
I second that.
All in favor or discussion? All in favor?
Aye.
Do I get to
Aye.
vote? I'm not even sure.
Aye.
If I'm not allowed to
You're all
vote,
too
don't
kind.
vote.
Are there any no's?
You can vote.
Are there any nays? Well, thank you so much for your faith in Kelly and I. We will continue our service through June or July, I guess, by the sounds of things.
Thank you both for your willingness to continue to take on this leadership role. We really appreciate it.
Very kind. Thank you.
I apologize. I have to step out to cover another meeting.
Thanks, Henry.
Thanks, Henry. Okay. Thank you to Kelly and Lisa Britt. I know I didn't formally solicit your willingness to accept these nominations, so thank you for doing so. On other items related to MAC and BAC transition. So we have moved to our quarterly cadence for MAC, and this does mean that we go longer in between meetings without hearing about proposed rules from the department. In the past, we've brought proposed rules to every monthly agenda to go on the consent agenda, and then members can, in the meeting, request to take them off consent and discuss or request more information from the department. In my 3 years of working with the MAC, what I've noticed is that the majority of these we don't discuss, and I don't know if the department always provides as much context as would be helpful. It's a lot of content to go through if that's not part of your normal role. It can be very technical or unclear, what the main change is. So I wanted to propose what I think could be some improvements as we move to the quarterly cadence, but I want to hear from everyone and we can take it up in our next meeting. What we could do is start sending out these proposed rules on a monthly cadence by email and include in that email just a brief summary of what are the changes in these proposed rules, what are they about, sort of like a digest. And then in that email, anyone in the MAC could reply to request that we set up a meeting to discuss, provide more information. And so then even if we didn't have our next scheduled meeting for like 2 months, we would just go ahead and put an ad hoc meeting together just around that rule and any questions or concerns about it. So this way, you know, it'd be really at the direction of MAC if we do have further discussion on it. We don't have to wait for the next quarterly meeting. And then we could also, you know, use this as an opportunity to just add a little bit more context for the forum on what these rules are doing. I think there's always going to be proposed rules that we know are going to be like very consequential and of interest. And so for those, we can also, you know, have more of a plan to like reserve agenda time, which we do today. When there are rules where we're changing a lot of things about the program. The other option, you know, there's other ways to do this. We could also like have a standing monthly meeting. I just think we may end up canceling. We're not getting a lot of attendance on that if it's just about consent agenda rules. And then I'm open to other suggestions too. So I'm going to stop talking there and just see if anyone has any questions or reactions on that. Doris.
I like that idea. It makes this meeting more dynamic and takes off something, or at least some things that could be pro forma. It allows members to engage before the meeting and prepare, which is always something that I appreciate in meetings that I participate in, when people truly are engaged and not just, you know, here because perhaps they have to be or other reasons. So I like option one quite a bit.
Any other comments, questions, Dee?
I really like the idea of option one of some sort of a plain language summary.
It's a good term.
Of
Yeah.
main changes.
Yeah, thank you.
And I agree with Olivia that the department usually has pretty good intel about whether a rule has any potential for controversy. But some of these rules, like many of the ones that we had on the consent agenda today, are renewal without change to prevent expiration, right? So those feel much less consequential, and in this way we can maybe make better use of our precious time together.
Any other questions or comments? This is all very helpful. I'll keep it on the agenda for next meeting so we can kind of revisit if there's any other thoughts that arise.
And in the interim, we'll do the monthly.
Yes, in the interim, we will send out bi-monthly, but then we'll also, you know, recap it all on the agenda so you can see what transpired. And then I just wanted to thank, I know we have a couple members of the BAC on our call today. We had our kickoff meeting, which was great. It was wonderful to meet some new faces and get things started. We are continuing to recruit for the Beneficiary Advisory Council, particularly trying to identify some more adults who are themselves Medicaid recipients. And we'll keep the group updated as those recruitment efforts develop. In our first meeting, we did focus on introductions, giving context for the creation of the BAC and what the MAC has done historically. But we've already identified some great ideas coming from BAC feedback for future meetings. These included how the department can best provide public information and support for those impacted by changes on open enrollment. So even if they're not on Medicaid currently, if something is changing with their qualified health plan or ACA coverage or Medicare coverage, how that can interplay with Medicaid services. We also got feedback on the dental network and ensuring that dentists are having open appointments for Medicaid patients, and some other topics as well.
DHHS communications, like those forms, I had submitted that. I know I sent it to him and I thought he.
Yeah. So to bring that to
Yes.
the BAC going forward, yes. But this was like came up in the BAC members initially. So Oh, Carolyn, go ahead.
No, she
I
just.
see your
Carolyn,
hand
did you have
raised,
a
Carolyn,
question?
but yeah, I don't think you're off yet.
Sorry. I was trying to raise my hand and got disconnected. On the rule issue, what happens to the existing subcommittees? For example, on the 805?
No changes there. So I don't think this would impact any existing subcommittee. I think the only one I know of is the 805. And then just like today, if anyone wanted to, request to start a subcommittee, we, like the idea of the monthly email is you would be able to do that just from the email. So if you saw something on there, I wanted to start a subcommittee, we could then start to set that up again without waiting for the next quarterly scheduled meeting.
Okay, thank you.
Yeah, no, it's a good point. I don't think I talked about subcommittees in particular, so thank you for raising that.
Kathy?
I have a cold, so I don't know if anyone can understand me or not. But I was just curious. I was at that meeting. And I was just curious, is there a limit to the number of people that can be on the committee?
No.
Because I would like to see a few more people with, like, direct participants, like people with disabilities. Because
Yeah.
I think I was the only one. And
I think you were too, the only person who themselves had, person with disability. That experience. No, there's not a formal limit. We definitely want to recruit more people, so we welcome that. And the only consideration is just logistics, right? Like if we had at a certain point such a big group, it would get harder to schedule and organize, but there's not a like regulatory limit on participants, and I definitely agree with you. We have room for more.
Well, I think that online works much better for most people, so I hope we keep it that way.
We will always provide online options for meetings. Yeah, it's not going anywhere. Yeah, thank you for your participation. Marissa, your hand is raised.
My question kind of follows up Kathy's. Did you have, was there a lack of participants because there were just not a lot of applicants who had disabilities who applied? Or were there barriers that were observed in people who were applying to be part of the BAC?
So I think probably both. We did get a good number of applicants. That there was a strong representation from parent caregivers in the applicants, which is of course a very important perspective for the Medicaid program. But we were concerned about having a group that was almost entirely representing that perspective. And so for that reason, we wanted to like hold slots to recruit for folks who are themselves receiving Medicaid and, like Kathy said, maybe the perspective of a person with disability or special healthcare needs on the program. We're also trying to balance geographically as well, make sure not everyone's from the same part of the state. So while it wasn't the case that I think we got overall too few applications, I think there was maybe not the breadth of experience that we were hoping to put together. And so I think that has informed our follow-up recruitment efforts, following up with department staff and community partners who work more with those groups and trying to make awareness of the opportunity to join the BAC. To answer your question, Marissa?
Yeah, I mean, I think just for those of us who have a lot of access to individuals with disability, I'm 100% with Kathy. I think there needs to be there's a different experience of a parent caregiver as opposed to somebody with a disability.
Absolutely different, yes.
And that's really important. So that just kind of, it's helpful to know that if you're recruiting, that we need to access those individuals with lived experience. So thank you.
Before we go to D, who was next? and then Kathy. We put out a big call for a lot of months, I did personally in the community, trying to get individuals in various categories of aid here at the department. So just for my information, they could still apply
Yes,
because it's open.
absolutely. Yeah, and you know what? That's a good point. I think we should probably update our flyer. And make sure that's clear now that it's more of kind of a open call. So we will do that, and then we'll share with the MAC an updated recruitment flyer.
And the webpage too.
And the webpage.
Yeah.
Dee?
That's what I was gonna ask for.
Oh.
I'm good.
Joan?
Good morning. Yes, my work with IDD individuals and their family caregivers and their group caregivers, really, for me, when you are looking at bringing them onto a meeting like an MAC, those with disabilities, you're talking about access points and what is involved in bringing them actually to that meeting. And so I think that maybe you want to look at bringing parent advocates, having them come with their person that is receiving the benefits. Or if you want that person to come alone, you're going to have to reach out and provide some other levels of access. It's just different. It's different than what we do when we come to a meeting. When you're putting all these other steps for someone to come to a meeting and be involved, that it does require a higher level of service care in order to make that happen. That's
Thanks for your comment.
And also, we can think about working people who are on Medicaid, parents of children maybe who don't experience disabilities. I think Olivia's larger point is we would love a diverse representation of consumers on the BAC. So I guess my encouragement to everyone, since flyers only do so much, but we all have huge networks that we could be potentially recruiting from to build up a really strong and diverse BAC.
At least Brett. Kathy?
Here's what I think. Okay. You have to put a notice out like Granite State Independent Living, and they'll put it out to everybody, and then maybe the DD Council, maybe some of their board members would like to be on the BAC. They have access to a lot of people and support to understand things. So you should try those two agencies. And because I get notices from Granite State, I had a lot more than I get from you guys. And I think I didn't see anything on either of those two major agencies, so I think you should try that. And I think you should also believe that individuals can handle it without, if someone wants to be on that, they're gonna know they're gonna care about the issues, and they're gonna understand them, because we live it. So, and I have absolutely nothing against parents. I just wrote a blog about how supportive parents have been but the point of view is way different. So it's important.
We need lots of perspectives, Kathy. I think we all agree with you on that. And I think that's why Olivia is sort of surfacing that today, that this is a real call to all of us to think about who's in our network and who could really bring a good perspective to the conversations of the BAC. So certainly, you know, like I said, I bet most of us could think of one or two people that might bring a lot of value and perspective. And, you know, maybe we just need to reach out to that person and say, there's this new opportunity to be more engaged in the Medicaid program, and I think you would be great at it.
I appreciate
Hi,
everyone's, oh, sorry, go ahead.
Hi, this is Ellen. I just have a couple questions. What is the time commitment that you are asking for with people coming onto the committee?
Is a quarterly meeting. So the commitment is to attend a quarterly meeting. Right now they're an hour, although I think if we had, you know, like a fuller agenda, we might do a longer meeting. And it's probably, you know, about half an hour in advance of the meeting to review anything we send or respond to scheduling emails. Right. So that's kind of the rough time commitment.
Great. And the next question is, just how accessible is it going to be for people that need hard copies of things? Because even with our committee, I have a really hard time because I need hard copies and I can't get them before the meetings. And so following along with the meeting is really difficult for somebody like me who does not have a computer and has no other way to take the information in terms of what I need cognitively. So now you're thinking about going to consumers. How flexible can you be in terms of providing the material if they're needed in a different type of way, like hard copies?
Yeah, it's a great point. In our sort of recruitment form, or the form people fill out to say that they're interested, we ask, you know, what is needed to support their participation. Yeah. Any accommodations. So that could be like interpretation in the virtual meeting services, or mailing out. I think we mentioned mailing out hard copies. You're absolutely right that with the MAC, we don't have materials far enough advanced to do hard copies in advance. That is the limitation we have right now with MAC. And I think if we had folks on the BAC requesting that, that would have to really direct how we structure the agenda to make sure, you know, it's in line with a hard copy distribution.
And Olivia, I think even with the MAC moving to the quarterly cadence, that might improve our ability to get hard copies in the hands of members who need it. Because, you know, trying to do it 12 months is a lot, but maybe this gives a little bit more runway for us.
Yeah, that's a good point, Lisa Brett.
That would be extremely helpful for some of us. Thanks.
Yeah, thank you for servicing that.
Richard.
Oh yeah, I saw the note in the chat. So we are currently talking with the BAC about whether the meeting is public. I think that's something that has to be sort of directed by the members. It may not be totally the same as MAC. It might be more agenda driven, like maybe there will be sometimes a public meeting and sometimes not. So we really want that to be kind of at the direction of the BAC itself. So when that's worked out, we will share it.
Great. Olivia, do you have anything else on the transition before we get into legislative updates, state and federal?
I don't. I will pass it to my colleague Rob.
Hello, everybody. So I will start with, I guess, some leftovers from last year, big leftovers though. So as you may recall, as you no doubt recall, HB2 implemented community engagement requirements again, specifically require the department to resubmit an 1115 waiver to implement the community engagement requirements as they currently exist in 126 AA. At the same time, SB 134, which had, well, I guess that was actually introduced first. SB 134 had identical language that eventually ended up in HB 2, had been retained by the House Health and Human Services and Elderly Affairs Committee. And work was being done on it throughout the fall. And that work has come to a head, and they've amended SB 134 and will be voting on an amendment to that bill this Wednesday. Essentially, what the amendment will do is it will align the work requirements, so the community engagement requirements, with the requirements that came out of the One Big Beautiful Bill Act that passed this summer. So it will do a few things, and I'll go through it as much as I can. I don't know if this amendment is public. I wish Henry were here because I have not been attending the actual hearing, so I don't know what's been discussed. So I'll speak about it in very broad terms, but I will let you know what it does. But what it does do is it delays the implementation of community engagement requirements until December 1st of 2026. It does not require the use of an 1115 waiver. I think the intent is to go with a state plan amendment, but I don't know if we're set in stone on that, David. Is that true?
We expect CMS to.
We'll be using the SPA, but it's the, yeah, okay. And then we will still be submitting quarterly reports as requested originally, but we'll be doing it a little bit differently than before. But I don't think anybody's as excited about reports as we are here. Also, this amendment would suspend the requirements of 126 AA2, which are the current community engagement requirements in New Hampshire law. So the 100 hours and the exemptions and things like that. And that the purpose of that is so we can align it with the requirements in the One Big Beautiful Bill Act.
And we'd anticipate a statute to promulgate that or not?
So the bill, what this amendment will do is the chapter law will suspend it.
Mm-hmm.
So there will be language in there that deals with how the suspension will be handled should certain things occur.
Okay.
Such as, legal action, strike downs, things like that. So it's not repealing the requirements, it's just putting them on ice, so to speak. Maybe that's a bad choice for it.
Okay.
They're putting it on hold. Also, there will be some language that incorporates much of the provisions of the One Big Beautiful Bill Act as well to outline how we'll be implementing it. So like I said, that'll be handled on Wednesday morning before the House Health and Services Committee. From there, it would have to be voted on by the full House again. And then the Senate, and then have to be signed by the governor's office. So still a little bit of time to go, but it would delay the implementation, I think, to December 1st, 2026, which I think is the big one for everybody here, as well as aligning it more closely with the One Big Beautiful Bill Act. So I think those are the two key points here. That
But you anticipate then that following those votes is when we would have a good indicator of the guardrails that would be in place that we need to be aware of to support people.
Yes. Yeah.
Thank you.
Yeah. I mean, like I said, it might be public language already. I just don't know because I haven't been attending that.
Yeah.
But like I said, when Henry comes back, he might actually be able to say, hey, it's public language.
Yeah, well, one piece we won't know is, we're still waiting for CMS to finalize their guidance and rules around what would meet the work requirement, so I think there will be some changes when that comes out, which is probably.
Because as I recall, when we asked about this, maybe in our last meeting, or even 2 meetings ago, but probably the last meeting, that Henry or you had provided the clarity that while we had a federal directive, we didn't have any details behind it. And so we're really still waiting for the feds to work out their details so that we can take those and operationalize them. Is that fair?
Yeah, and specifically around the definition of what would meet an exception under the federal law.
Okay. Thank you.
But I think like I said, the important thing is here is we're supposed to implement this by January 1st. So 2 months from now, we now have over here,
Thank you.
Which I think is the key takeaway. And we have some, we get to take away some of the more stringent measures that we had in New Hampshire law that don't exist on the federal level, such as, we're at the 80-hour level as opposed to the 100-hour level. So,
We have a question from Holly and then just an ask to speak up in the room.
oh, I'm sorry. Usually nobody accuses me of that.
Rob, I just had a question about the interplay between the look back of the either 1 to 3 months, I guess it's 3 months right now, and the amendment about you have to have been working for 3 months in the past in order to qualify for Medicaid. How is the interplay between that and the exemption process? I guess my detailed question is, if there's somebody who has commercial insurance who needs to be hospitalized for an extended period of time, loses their insurance, has to go on Medicaid, how does that work under the amendments that are being proposed?
Dave, do you have any thoughts on that?
I mean, the amendments aren't getting into that level of detail.
Yeah, I don't think,
of like every situation and whether an exemption would apply.
Yeah, unfortunately, I guess I don't have a good answer for that, Holly, and I think it's one of those things where we don't have a lot of detail on that at the moment, other than just we have the 3 consecutive months in the amendment right now, and it's a level of detail that will be worked out as time goes on.
And I think we'd expect to see that detail in the rule that gets proposed from CMS, which we've been told is scheduled for the spring. The issue.
Thank you.
And that's what I have for the leftovers from last session. Now I did put together a list of upcoming LSRs for this coming session. Did you guys get that out before?
I didn't.
Okay, and I know I'm looking at the time. It's just a lot of titles, not a lot of substance. And what the language I have seen, I actually can't even tell you because it's still confidential. So I can read the titles to you. I don't know if you want to hear me read titles. But what I will tell you is that they will be sent out to you guys after the meeting. This is what I'm tracking right now. I highlighted what I thought was the most interesting so far. These are based on what the Gen Court website is publicly listed. There are confidential LSRs. Oh, there you go. That's my handiwork there. There are confidential LSRs that are not listed that I am aware of because we are doing fiscal note worksheets as we speak that I think are interesting that probably should be out there, but I can't put on there yet. But if there's anything on there or that should be on there that you're aware of that is listed on the Gen Core website, please feel free to drop me a line and I will add it to it. But I did add what I thought was interesting for now, and there's about a little over 100 right now. that I will, take away as, or add and subtract as we go through it. But yes.
It's really for Olivia.
So, Olivia, I'm wondering, we have a commitment to send a communication to the members, monthly with rule updates. I wonder if the members, and I'm speaking kind of for myself, would also appreciate the legislative update on a monthly basis, at least,
That's what I was gonna say.
January through June, because, that is something that was really helpful when we were meeting on a monthly basis, but you could miss fully half of the session in between meetings or miss opportunities to get engaged on a certain issue. I'm like, I hate adding to the task list, but I feel like this is another one of those things that when we met monthly was really helpful for people.
When would it be due on a monthly basis? The first of the month, the 15th of the month, just so I could have it in my queue.
We can work that out probably.
Okay.
Yeah, we can work that out with you.
Okay.
Because maybe we can try to align it to the rule, like the monthly rules.
I can do that, certainly. Yeah.
Have it all out together.
Instead of having multiple emails.
Yeah, so
For
it gives
me.
you guys a bunch
Yeah.
of emails throughout the month.
Yeah,
so.
I can certainly do that. Just keep up with
Yeah,
the status of things.
we'll let you know.
Yeah.
And then maybe, Kelly and I can think about, if there are times that we as the chair and vice chair of the committee want to encourage participation among members on a particular piece of legislation. I know you all at the department can't necessarily or wouldn't necessarily do that, but Kelly or I might say this is potentially impactful, and the more people who could participate, the better.
I mean, I'm happy to answer questions through emails about what's going on with certain things as well, to the extent that I've been actually going to the hearings. A lot of times I'm just following them through just the dockets, or occasionally going back and watching the YouTube stream of them if I don't go to all of them. I don't attend all 100 hearings. I'm not that,
Why not?
It's pretty hard to attend the 15 or so I do actually go to. But I'm happy to answer questions as much as I can as well through emails. I don't mind doing that.
Great. Any other questions?
So there's no other questions for Rob. We were also just gonna give a brief update on the rural health transformation program. Just gonna turn it to Dave for that.
Yeah, so we submitted under the HR1, the one big beautiful bill, or OB3, or OBA, various names it goes by these days. There was a $50 billion award program for states to make investments into making rural communities healthier through investments with primary care, prevention initiatives, chronic disease management, rural hospitals, community mental health centers, FQHCs. And the notice of funding opportunity was released, I think, September 15th, and it had a due date of last week. And so the state did submit its application. There's a 4-page summary on the department's website. You can certainly send out a link to it. And the governor also issued an executive order on it, establishing a new office within the governor's office that will work on the rural health transformation initiatives. It's called, I'm forgetting the full name, but it boils down, the acronym is Go North. And the investments New Hampshire intends to make that are in the application that was submitted for CMS's review and approval is around increasing access to primary care, doing prevention, chronic disease management, investments into mobile integrated health, advancements around trying to help with interoperability, care coordination, community health workers, and our workforce initiative to create rural healthcare career pathways. And if you think about it on a continuum from you could be at a high school technical education program and get involved in healthcare, and then your next step could be going to the community college system to get a higher level of certification or degree, and then you could go through the university system for a higher level nursing degree or a physician assistant degree. And so really coordinating and developing those pathways so that people that could grow up in those communities that are interested in a career in healthcare can access education and then be employed at a local healthcare facility. But I think there will be a lot more to come. So CMS is reviewing all states' applications. We were told to budget for $200 million a year. All states were. We expect CMS to come back with something else, probably a little lower than that. It really depends on the scoring factors in the application, which part of it is at CMS's discretion as to whether or not how much they liked the state's initiatives, and the other piece is on how rural a state is. So while New Hampshire has a lot of rural area within the state, it's small in size, and one of the metrics is like square miles of rural area. So you think of a state like Alaska, they get a lot more points there than we do. But we do well for a percentage of our population that lives in a rural area, so it's sort of like we're not quite sure where we'll come out on that. But so we'll enter into negotiations with CMS over the next 6 weeks, and we'll get our final award amount by the end of the year. And I think at that point we'll have a lot more details to share on where the money's going, within initiatives and what it will be spent on. So a lot more to come on that, but it was a really significant amount of work and a relatively public process where we had a request for information out there, and we got over 200 responses, and we had lots of meetings with lots of stakeholders, the community mental health centers, the FQHCs, the hospitals, local providers, community-based organizations, and tried to bring in all the information around what the needs are and what the interests are. And then we had to boil it down. Henry called it boiling sap, but we boiled it down to 60 pages for CMS, double spaced too.
So, any questions, comments? In the interest of time, I do want to make sure we keep moving along to the post-award forum, but like was said earlier in the meeting, we're going to keep federal state updates on the agenda to make sure that there's a chance to ask questions and share information on that front. Lisa, Britt, are you okay with moving to the next agenda item?
You bet. So you want to do the post-award forum at this point, or you want to move ahead?
That was the next.
I'd like to make sure, that we get to post-award.
Okay. So let's go to Carolyn for the post-award forum for the 11-15, and then after that, the enrollment and eligibility updates.
Carolyn, do you want me to share those slides?
Please. And Dave, it's nice to see you. I haven't seen you in weeks. You've been in that room doing the grant, so it's nice to see you again. You can go to the next page. Thanks, Kristen.
Yep.
So there's 4 major components. I'm going to cut this quite short because I know we don't have a lot of time and there's a lot to these slides, so they will be coming to you. And if you have any questions, my contact information is at the end. There's 4 major components to this demonstration: the substance use disorder, serious mental illness, the denture benefit, and the community reentry. Those are the currently approved components of the waiver at this time. So we'll get into each piece as we go along. Go ahead, Kristen, the next one, please. For the SUD demonstration, that is for, the SUD benefit was approved July 10th of 2018, and the authority allows federal reimbursement for services provided in residential and inpatient treatment settings.
that qualify as an institution for mental disease for individuals that are age under 65. And for fiscal year 24, these are a few pieces of data that we were able to pull together. The number of demonstration participants with a claim for the SUD IMD demo was 2,377, and the average length of stay for eligible stays in an IMD for SUD was 16 days. And that's for state fiscal year of 24. So next slide, please. Sorry, I'm gonna barrel through this, so in the interest of time. So the SMI waiver is the SMI portion of the demonstration, was approved on June 2nd of 2022. And this is for Medicaid reimbursement for services provided for Medicaid beneficiaries age 21 to 64 with serious mental illness for qualifying IMD stays. So this is New Hampshire Hospital and Hampstead are the only two currently participating in the SMI component of the demonstration. And again, a few data points that were for fiscal year 24. The number of demonstration participants with the claim was 184, and the average length of stay for eligible stays was 18 days in 24. So next slide, please. The denture benefit. The denture benefit began on April 1st of 2023, and the coverage for this part of the 1115 denture benefit covers removable, partial, or full dentures for individuals 21 and older who reside in nursing facilities. And these dentures can be once every 5 years or as medically necessary, or for repairs when medically needed. So there were 174 denture claims in fiscal year 25. 159 were for complete denture, 159 were for complete dentures and 15 were for partial dentures or repairs. And this data came from the dental director. So if you have questions on that piece of it, I can definitely be the go-between to get answers on anything you have for the denture benefit. Next slide, please. Community reentry. This one's a little fuller. This is our newest addition to the 1115. This was implemented on January 1st of 2025, and community reentry was an added Medicaid benefit for incarcerated individuals with behavioral health needs, and these are eligible members who can receive pre-release services 45 days prior to their release from being in custody. They are for adjudicated individuals. At first, we started with New Hampshire State Prisons and Sununu Youth Center is what we have so far. We are transitioning to counties, but that's coming in phases. The limited benefit includes Medicaid outreach and enrollment, enhanced care coordination, MAT, medication assisted treatment, a 30-day prescription drug supply at release, and community provider appointments and linkages for those appointments. So here's some data points. There's some really great information here, and clearly from early indicators, we have some work to do. 210 members we've had so far. 91 of those members have been released. We've had 9 participants be reincarcerated. That's a lot of the question. I usually get a lot of, that's a top question that I get. We don't think that that's as high as the national statistics have been coming out. We've done a little tiny bit of research on it, and it's not bad for early indicators. 82% of our participants have had Medicaid cards in hand. Our goal is 100%. That's more administrative issues at this point, so that we're really working through. So there are a few issues that we still need to work on, but one member has died post-release so far. So we're getting there. People are getting services and getting what they need. So this is just a snapshot of what we've been doing so far. So next slide, please. We like to share a little bit. If we get stories from members or managed care organizations, we do like to share if we get any kind of stories about what's been happening. So this is just a brief vignette of an actual member who's 25 years old. They were recently released after a 5-year incarceration. And you can see they have a support system. They're the MCO reentry team was notified of their eligibility on May 12th. They were released on June 26th. So they were able to get care management engagement, post-release appointments, and get them a care plan together for them. There's many facets to this working. Department of Corrections care managers, the MCO social worker care manager, behavioral health, all these people are working together to establish these plans and make it successful for the member post-release. They found immediate needs for this person, establishing both primary care and behavioral health connections, addressing food insecurities, and securing housing assistance for this member. So the next slide. These are the positive post-release outcomes and early indicators for community reentry. So this is for the same person. The care manager was engaging with the member regularly, and they're constant. We monitor that weekly, and they send us weekly reports. They get them transportation. They get them access to behavioral health services. Primary care connections are made quite often. Housing stability, and they get them, applied for SNAP benefits and were approved. So it's just been a positive program so far, and we're really looking forward to the future and making it even better and stronger of a program. So we're really happy so far with what's been going on. So next slide. So these are some of the provider accomplishments for demonstration. We're calling it demonstration year 7. So 3 certified CCBHCs have launched, 2 in January of 25 and 1 in July. 2 crisis centers have opened, and the opioid treatment provider audit tool, it helps the MCOs ensure that the OTPs are providing interventions that are appropriate for the diagnosis and level of care, and training happened. All 3 OTPs begin using the tool in 2025, and a new SUD audit tool is being used for the SUD providers in 2025. Next. Service accomplishment. So expanded distribution for and access for naloxone and targeted case management for SUD is available effective January 2025. In March of 24, DHHS into a contract with Unite USA for closed loop referral and point click care for event notification for admission, discharge, and transfers. And as I just went through, community reentry launched in January of 2025. Next. We have to submit a midpoint assessment for our demonstration to CMS, and they do have it in draft form just because they've been having a lot of delays in submissions with us. But I was able to submit some of the reports that are in draft currently, but these are a few things that they measure. The average length of stay in an IMD was less than the 30-day threshold set by CMS. In early 2025, CMS approved a new value-based payment model that incorporates a risk-based adjustment for each eligible CMHC for behavioral health outpatient services. The state enhanced its contract with CMHCs to increase the community-based bed capacity across the state by 60 beds. Now we have 63 beds. And the percentage of psychiatric hospital discharges for adults 18 and older received follow-up within 7 days after discharge increased from 49% to 57% during the measurement period. And that was 2022 to 2023. So next slide, please. And that's pretty good. that's all I have. Is there any quick questions anyone has, or I'm happy to answer emails or any other questions you would have.
Carolyn, thank you for working under the time.
Sure.
allotted and getting it
Sorry, it was
done.
really quick,
Sorry
but-
to add that pressure to you.
Can I just make a quick comment? It's Ellen. I'm really, really impressed with all the accomplishments that you've made, and that recidivism rate of only 9 folks in the reentry program is dramatically lower than the general population that needs services that doesn't get it. So that number in itself is stunning. So thank you very much for all you've done.
Thank you.
Yeah, thanks for the presentation, Carolyn. The information you're providing and the data points are very comforting to see.
You want to,
Right, so
just another comment in terms of getting to the counties. Carolyn, do you want to update that?
Sure. So we are starting to implement in our county jail systems. So as everyone knows, we have 10 county jails. So we are starting our second round of talks with counties. We have started with one county. We are starting with the second county, doing our final readiness assessments, and we are creating an implementation plan. We are required to implement youth reentry in all 10 counties by December of 2026. So in hopes of meeting that goal, we need to really be aggressive in completing that task. So we do have some counties that are interested in implementing adult as well. And if they're ready, we're happy to accommodate that task. So that's where we're at now. And we hope to continue the progress and positive feedback we've been receiving from the county. So
We competed for a federal grant to support that effort.
yes, we received a 4-year grant that will help us get some staffing and some startup funds for these counties that are lacking in some areas that we could support them with, technology, other areas that they may need some assistance with. So those grant funds will be put to use and quickly. So we're working on that as well to see where we can help them and build up their systems or whatever they may need to help with move them forward in this process.
That's a 4-year grant up to, depending on how we perform, 4.6 million.
4.6 million, yes. Yeah.
that's great. Terrific.
Hopefully next year we'll have even more.
Thank you, Carolyn. So we have 5 minutes left. Olivia, which of the things that are left on the agenda would you like to spend our last few minutes together on?
Well, I think you could probably provide eligibility enrollment by email unless there's anything you would strongly wish to present.
No, I think I have the deck ready, so we can send it via email. Based on the conversation from last month, you'll see a new slide just to call out the other waiver groups. So ABD, IHS, Fast Forward is in there as well.
We'll send that out. We covered our MEA item earlier in the agenda. On adult dental, I'll just quickly say in October, we had over 4,000 claims submitted, which is the highest claim count we've had to date in the program on a monthly basis. We were happy to see that. And similarly, over 3,200 unique members served in October, also the highest monthly count that we achieved. So we were happy to see that. I'll share the full mobile schedule in follow-up to the meeting as well, which books out until the first of the year, as well as the network dashboard. Scott, do we have you for DDU, and is there anything you want to prioritize presenting or otherwise send your update out with materials?
Hi, yes, I'm here. Really nothing. I mean, unless anybody has any questions on the handout, in short, We're moving right along. Applications did pick up a slight bit in October compared to previous months and actually previous years. So it was our highest month. Still well within timeframes and looking good.
Thank you,
Fabulous.
Scott. Sorry, was there a question?
No, I was just saying fabulous.
We spoke about rural health already at an earlier agenda item. We also got to dive into reentry with the post-award forum that Carolyn presented. We'll continue to keep the link on here for our most current HCBS spending plan. And other than the 1115 updates we shared already, I don't think we have major updates across the waivers here. On Medicaid to schools, Jordan, if there's anything you want to highlight, we have been working with our vendor there to prepare for our changes in administrative claiming and certified public expenditures in Medicaid. And I think, Jordan, if I'm not wrong, there's going to be some upcoming forums in the months ahead that we can make sure to share on this meeting too for anyone who works with that community of providers.
And Jordan also applied for funding here to get a grant, and what was it, 2.5 million?
Yep.
To help support
2.5
that
million.
effort.
Excellent.
Cheryl Steinberg, just any update on the implementation of presumptive eligibility for waiver programs?
So the CMS and our meetings with them is just, it's they're working it internally. There's a lot going on federally with them in terms of what their priorities are in terms of having to respond to the OB3, and there's not much more we can do to try and dig it out other than to, we've done everything we can do to submit. It's up to them working it through their leadership, and there's been a lot of changes in their leadership. Third Medicaid director since the administration started. So that and the Office of Management Budget is busy with issues. So those are it's certainly on our radar to stay on top of, and we do as much as we can. They can't. This I guess it's disappointing that it's gone on longer than they said it would, but I understand that they've had stuff thrown on them that they didn't expect either.
Any questions or follow up on any of the last highlights here?
I know we're gonna wrap up really quickly. I just want to say, Kara, I'm speaking for you, but I'm really just speaking that we don't have an update anyways on the 805 subcommittee. We are waiting to hear back from
Thank
Brian.
you for raising. I'm sorry.
No, that's okay. It's in the next section.
Is Brian Clark still on? I saw him earlier.
See him.
Well, we don't have an update because we're waiting to hear back from Brian.
Yes, I was going to ask. We will get an update from Brian on when you can expect to hear an update.
It's 12 o'clock. Look at that.
I feel like we've made it through as many agenda items as we can. I think we did a great job on making sure we at least touched on some things. Provided there are no further questions and no other pressing agenda items, I would entertain a motion to adjourn.
So moved.
Do we have a second? All in favor? Aye.
Okay.
Thanks, everybody. See you soon.
Thank you.
Thanks so much. Have a great day.
Thank you. Thank you.
Bye, everybody.
Thank you.
Thank you.
You're welcome.
Thank you. Welcome to.
Thank you.